Good morning, everybody. Welcome to the course on imaging biomarkers for prostate cancer diagnosis, treatment, and monitoring. We'll start this morning by talking about imaging biomarkers. So here are my disclosures. So all of you should be familiar that there are multiple prognostic subgroups that are defined by clinical findings, histology, blood tests, bone scans, and CT scans, which are used to define these clinical states of prostate cancer. So you'll see suspected cancer there on the left, and then known cancer in the green, which are of different risk groups, and then we have hormone sensitive, and then the castration-resistant prostate cancer states. And you can see that you have metastases and non-metastases depending on bone scan and CT scan findings. And as you go from left to right, mutational heterogeneity increases, but curability, unfortunately, decreases. Now, categorizing patients in this way still results in high outcomes heterogeneities in any given state, ranging from the indolent to the rapidly progressive. And this is because of biopsy uncertainty, this imperfect classifier system, underlying genomic and molecular characteristics, and of course variable therapy effectiveness. And we need molecular and imaging biomarkers to personalize the care of patients with prostate cancer in order to improve their outcomes. So on the top left there, you've got this rather heterogeneous subgroup, and what we need are prognostic and predictive biomarkers that tell us who has got indolent cancer, the green folks who don't need any therapy, who's the usual type of patient who needs the standard treatment, who needs an escalated therapy, and which patient requires a completely different therapeutic approach. Essentially, we'll be talking about four categories of biomarkers today. Diagnostic biomarkers, which diagnose patients for the presence or an absence of a disease or a subtype of the disease. Prognostic biomarkers that tell us about the likely course of the disease in an untreated individual. A predictive biomarker that characterizes patients by the likelihood of response to a particular therapy. And of course, there are response biomarkers that show the biological response of a patient receiving a particular treatment. So the classical diagnostic biomarker is the PSA test, but PIRADS categories are also a diagnostic biomarker. So you can see that the higher the PIRAD score, the greater is the probability of clinically significant cancer. But you'll also notice how the higher the score, the greater is the likelihood of more aggressive types of cancer, and therefore the PIRAD score can also serve as a prognostic biomarker, although this has not yet been established. So prognostic biomarkers, there are multiple ones that we use in prostate cancer. So the rate of rise of a PSA in somebody on follow-up, so in the setting of biochemical recurrence, for example, can predict the likelihood of progression. Leeson score, of course, is a classical prognostic biomarker, but tumor extent or stage on a prostate MRI can also be very prognostic of a future outcome. Just by looking at the T2 images alone, you can prognosticate more accurately. So if you see no focal abnormality, the probability of a metastasis over 15 years is very, very low, and the prostate cancer-specific survival is almost zero. Whereas if you have a suspicious lesion which is invading the seminal vesicles and causing extraprostatic disease, then over time you can see that a lot of these patients pass away. In other words, this marker is acting as a prognostic marker. Predictive markers tell us about somebody who will or will not respond more favorably or unfavorably to a particular type of therapy. So the BRCA mutation, of course, will tell us if a patient is likely to benefit from using a PARP inhibitor. Another predictive biomarker is the bone scan. So a bone scan showing less than 4 bone metastases can predict who is likely to gain benefit from pelvic radiotherapy in the setting of metastatic hormone-sensitive prostate cancer. And another predictive biomarker is the ratio of the uptake on a PSMA PET compared to an FDG PET to predict the likelihood of response to an anti-PSMA directed therapy. So here, for example, are 4 categories of patients. So you can see on the left-hand side a man with a lot of FDG uptake, but very low uptake on a PSMA PET CT. This patient is highly unsuitable for anti-PSMA directed therapy, whereas this patient here, who has concordant elevated PSMA and an elevated FDG PET, is very suitable. And you can see on the right-hand side a man who has lots of avid disease on the PSMA PET but is negative on the FDG PET. This man would also be suitable, and you can show that by looking at the overall survival curves. Patients who are unsuitable live for shorter periods of time. Patients who are suitable live for 10 months more. So, as I said, we've got this problem of categorizing patients with highly heterogeneous outcomes, and we have the spectrum of disease from the indolent to the highly aggressive. So for indolent disease, the problem at the moment is over-treatments. And the type of biomarker we would need for this particular patient would be a prognostic biomarker. If you have highly aggressive disease, you know this patient needs something completely different. And new therapeutic strategies are needed, and so you would need to be able to spot those patients also. So that's a prognostic biomarker. And you've got the patients in the middle. These are the usual patients, or patients who are slightly elevated risk. Now, when you have the usual patients, say intermediate risk prostate cancer, and there's multiple treatment options, what do? So you can use surgery, you can use radiotherapy, you can use brachytherapy, you can use focal therapy, and you need a predictive biomarker for these sorts of patients to decide which patient should get which treatment. Similarly, for a slightly higher risk patient, you want to give them a little bit more treatment to control their disease. Again, you need a predictive biomarker. So prognostic biomarkers informs on a future outcome and are used to identify men with a very favorable response or those with very poor outcomes in whom therapy escalations provide no added benefits. Predictive biomarkers are needed when there are multiple therapy options and outcomes need to be improved. So, what type of biomarker would you need to reduce the diagnosis of indolent cancers that occurs with systematic biopsy? Do you need a diagnostic, prognostic, predictive biomarker? Well, in this particular instance, you're clearly trying to reduce the prevalence of clinically insignificant disease, and you need a diagnostic biomarker. And a classical diagnostic biomarker is an MRI scan with MRI-guided biopsy. So if you compare systematic biopsy to a targeted biopsy, you can see that there is about a 12% reduction in the diagnosis of clinically insignificant disease between systematic and targeted biopsies, 22% versus 10% in this prospective study. Okay, different question. What type of biomarker do you need to select men with intermediate risk favorable cancers who are suitable or unsuitable for active surveillance? For these patients, again, you need a diagnostic biomarker. And here is some data to show that. So this is a study that's recently been published in over 1,000 men undergoing a prostatectomy for grade group 2 disease. You can see that if you had a positive MRI, you are more likely to have adverse pathology on the prostatectomy specimen or disease upgrading. So the presence of a visible lesion predicted for an unfavorable pathology. And in fact, This has been shown by a number of papers. There are two major observations here. Number one, if you don't see anything on an MRI scan, in fact, about 10% of these patients who start off as having Gleason grade group 2 end up with having Gleason grade group 1. So in other words, they become downgraded. And on the flip side, if you have a grade group 2 abnormality and you have either a Pyreths 4 or a Pyreths 5 lesion, you should not undergo active surveillance because there is a higher probability of adverse pathology or upgrading, and you can see a number of studies have shown this. Okay, different question. What type of biomarker do you need for men on active surveillance to decide whether to continue a conservative therapy or to undertake an active management now? So they have a patient on active surveillance. What sort of biomarker would you need? Remember, you're trying to predict a future outcome. Remember, prognostic biomarkers inform on the likelihood of a future cancer outcome, favorable or unfavorable. So for this you would need a prognostic biomarker. And it turns out that MRI is also a prognostic biomarker in the setting of active surveillance of patients on active surveillance. So here patients on active surveillance having their second MRI and their MRI targeted biopsy. You can see how the presence of a Pyreths 3 or greater lesion or Pyreths 4 or greater lesion is associated with a greater probability of future upgrading and is associated with AS discontinuations. And in fact, if you had the same abnormality on the MRI before and on surveillance, you can see that it predicts for higher grade in the future and discontinuations. And any change that occurred between your baseline MRI and your follow-up MRI, that was also predictive of poor long-term outcomes. In other words, MRI in the follow-up of active surveillance is prognostic of a poor outcome in the future. Okay, last question. What type of imaging biomarker do you need to decide when a man with hormone-sensitive prostate cancer who is metastatic should get additional prostate radiotherapy? So you have a man with hormone-sensitive disease with metastatic disease, should you give them or should you not give them pelvic radiotherapy? So clearly we're trying to predict for a outcome, a favorable outcome. Remember, a predictive biomarker informs on the likely specific benefit to a therapy type. So we're talking about escalating the prostate in this particular instance. So you need a predictive biomarker. And it turns out that the number of lesions on a bone scan is predictive of overall survival. So if you have 3 or fewer bone metastases on a bone scan, it predicts for improved overall survival. If you have 4 or more bone metastases, you can see it predicts for the absence of benefit. And it turns out that the bone scan is predictive regardless of your performance status, regardless of your Gleason score, regardless of your tumor state, regardless of your nodal state. So it's highly predictive. So these are the take-home points. Diagnostic biomarkers can become prognostic or predictive biomarkers, but remember, prognostic and predictive biomarkers are not the same. Prognostic biomarkers are used to identify a future event, and prognostic biomarkers should be used to identify either patients with very favorable outcomes or very unfavorable outcomes where treatment intensification does not help. Predictive biomarkers should be used to identify individuals who are likely to experience a more favorable or an unfavorable effect from a therapy, and is used for the usual patients to determine which therapy option provides the best benefit. Thank you very much.